Hi, welcome. This is Peter Gay Klink. I have a Doctor of Pharmacy degree. I'm a pharmacist and a board-certified medication therapy management specialist. I'm speaking today on pharmacogenomic testing. Why do we do it? As a relatively new area of medicine, I hope you'll come to understand and value pharmacogenomic testing and hopefully decide that you will have your own genome tested so that you can be more knowledgeable and have your provider be more knowledgeable about medications that will work best for you. What is pharmacogenomics? Pharmacogenomics is a study of how genes affect a person's response to drugs. This is a relatively new field which combines pharmacology, the science of drugs, and genomics, the study of genes and their functions, and to develop effective, safe medications in doses that will be tailored to a person's genetic makeup. And this is the definition according to the National Library of Medicine. Pharmacogenomic testing, this field of medicine is also known as personalized medicine, concierge medicine, or precision medicine. The long-term goal of pharmacogenomics is to help doctors select the drugs and doses best suited for each person. It is part of the field of precision medicine, which helps to treat each patient individually, because each of us is different and our genetic makeup is different, even if we have siblings or a twin. We all are a little different. What are we doing currently in medicine? How are medications currently prescribed? Right now we're doing one size fits all. Drugs don't work the same for everyone, even if we're very closely related genetically. And it's difficult to predict who will benefit from a medication, who will not respond, and who will have adverse drug reactions or negative effects. In the U.S., side effects are responsible for a significant number of hospitalizations and deaths each year. 1 in 5 injuries or deaths per year while in the hospital is due to adverse drug reactions. And there's an estimated cost of $177 billion in the year 2000, which is more than cardiovascular disease or diabetes. It is the fourth leading cause of death, and it's ranked above pulmonary disease, diabetes, AIDS, pneumonia, accidents, and automobile deaths. So, adverse drug reactions play a significant part in the leading cause of death in our population. What can pharmacogenomics predict? Based on your genetic makeup and your genetic differences, pharmacogenomics can predict whether a medication will be effective for you or whether you are more likely to have adverse drug reactions or side effects. An example of pharmacogenomics helping with finding you an effective medication is how many mood stabilizers or antidepressants does the typical patient try before finding one that really works? Often a patient will have to try many, and each may take up to 6 to 8 weeks before the provider is able to figure out if that medication is the one that will work best for you. And sometimes, even after trying a medication and the provider feels that it's working, a second medication might need to be added because the first one isn't doing an effective job. Wouldn't it be nice to know which medications are most likely to work for you before you start therapy? And maybe you might be able to find Maybe you might still need 2 or 3 medications to control your depression or stabilize your mood, but at least you'd know that these are the most effective ones for you. And then there's a case of others that have tried so many medications already, and they feel that none of them are working. Wouldn't it be nice to know which is most likely to work, and then you'd be able to discontinue ineffective medications and actually be on ones that you know are supposed to be the most effective ones for you. Having this knowledge is power, and it empowers us and helps us to feel that we're getting the best care that we can receive. So with pharmacogenomic testing, you can be treated effectively. It can stop suffering. It brings on more happiness and increases productivity because it decreases the amount of time you're away from work and family as you try to figure out how to effectively treat your condition. So hopefully patients can see the value of pharmacogenomic testing as we keep working on this presentation. Conditions that affect response to drugs. Some of these conditions include clopidogrel resistance, warfarin sensitivity, warfarin resistance, malignant hypothermia, Stevens-Johnson syndrome or SJS, toxic epidermal necrolysis or TENS, thiopurine S-methyltransferase deficiency. More information about this can be found at NIH under their genomic research section of their website. Clopidogrel resistance is a condition in which the clopidogrel drug or Plavix is less effective than in a person that metabolizes this drug normally. And clopidogrel is an antiplatelet drug which is often used in patients who have had a stroke, a heart attack, blood clots in the deep veins of their extremities, so patients that have had deep vein thrombosis. And it's also used to prevent plaque accumulation on stents, and stents are usually used in blood vessels leading away from the heart. Clopidogrel is a prodrug, and it has to be metabolized to the active form in order to work. It prevents, like I said before, clotting or aggregation of platelets, which will result in blood clots. So people who are resistant to clopidogrel are usually one of 2 categories. They are intermediate metabolizers or they are poor metabolizers. Intermediate metabolizers get some functionality from their genes, and they're able to process some clopidogrel, but they don't get the full benefit of the drug because they are not processing it completely. And so they are still at an increased risk to develop blood clots. Poor metabolizers have very limited or no benefit from this medication because they process it very poorly, and as a result have significant risk of developing blood clots. In warfarin sensitivity, the patient has a low tolerance for warfarin. Warfarin is usually used to prevent blood clots in people with heart valve disease, and also for patients who have irregular heartbeats or who have had a stroke or also a deep vein thrombosis or a blood clot. So in people that are sensitive to warfarin, it takes longer than normal for them to process this medication, which increases their risk for adverse side effects. And these patients are often considered poor metabolizers. And as a result, they take a longer time to process warfarin, and it builds up in their system and can result in bleeding in the brain, in the gastrointestinal tract, and other tissues, which can lead to serious health problems or even death. In warfarin resistance, it's a little bit similar to clopidogrel resistance in the fact that patients have or may have incomplete or complete resistance to warfarin. And what this means is that some patients, if the dose is high enough, they can have a response to warfarin. However, other patients, regardless of how high the dose is, they do not respond to treatment with warfarin. And so in both cases, the patient is at a increased risk of developing a blood clot. In both cases, it just has to do with how the patient's body processes warfarin. And for those that are rapidly processing this medication, they're often called rapid metabolizers or fast metabolizers. They are breaking down the medication so quickly that it doesn't have a chance to anticoagulate or work like it should. And as a result, the patient is at an increased risk for blood clots. Patients with malignant hypothermia, in this case, the patient has a severe reaction to the medication, to certain medications, and usually these medications are anesthetic gases, and which are used to block the sensation of pain during surgery, and sometimes with muscle relaxants also. And what happens with these patients is they develop an extremely high fever. Their muscle fibers start to break down, which is called rhabdomyolysis, and they have increased acid in their blood, resulting in acidosis, and a rapid heart rate. And without prompt treatment, this can be life-threatening. And so people are at an increased risk for this disorder when they are not able to process these medications effectively. In Stevens-Johnson syndrome or toxic epidermal necrolysis, these conditions are usually brought on by certain medications like anti-seizure medications, and in these conditions, they're actually a continuum of the condition. The Stevens-Johnson syndrome is a more mild version of toxic epidermal necrolysis, and what happens in this is that the patient develops fever and flu-like symptoms within a few days of beginning the medication, and their skin starts to blister and peel, and these skin erosions can become so severe that they cover a significant portion of the body, and it can affect your eyes, your mouth, your mucous membranes, airways, It can affect your swallowing and breathing. And it can cause, sometimes, depending on the severity, it can cause lifelong problems associated with the damage to the skin. And in some cases, patients with Stevens-Johnson syndrome, in about 10% of the cases, it can result in fatality, and in up to about 50% of the cases of TENS, it can result in fatality. So these are serious conditions that it would be best to know if you're able to process those medications effectively before being put on them. And this is a question that pharmacogenomic testing can also answer for you. Lastly, let's talk about thiopurine S-methyltransferase deficiency. This condition results because a patient is deficient in the enzyme or the genomic makeup that processes medications that belong to the 6-thioguanine, 6-mercaptopurine, and azathioprine groups. And these medications inhibit or suppresses the body's immune system. So they're often used in conditions such as Crohn's disease, rheumatoid arthritis, and sometimes in cancer. And so these medications have the tendency to damage the bone marrow. And so if a patient is deficient in their gene to process these medications, then they can have resultant bone marrow damage. And so it's really important to also know your genomic makeup before receiving this medication. So some of the benefits of pharmacogenomic testing is that it can be used to influence current and future medication selection. Your genes are going to stay the same, so your results are valid for life. There may be new developments in terms of additional information on drugs that become available for use, but your genes will stay the same, and they continue to search and interrogate new genes, and they will just add that to your medical records. Pharmacogenomic testing reduces prescribing trial and error. It helps to guide initial dosing, and it predicts who is most likely to have side effects. For example, poor metabolizers. There are some limitations to pharmacogenomic testing. Pharmacogenomic testing is not whole genome sequencing or testing, and so it will not predict risk for disease. It will not predict allergies. It gives information of more appropriate drugs, however, which does not mean that the patient will not experience side effects, but it does predict that the lower risk of side effects with a particular drug. It gives information on less effective drugs for ultra metabolizers, patients that process a medication so quickly that a medication does not have a chance to work for them. It gives information on drugs that are more likely to cause side effects, that, like in the case of poor metabolizers. In these patients, the medication is just not being processed at an adequate rate, and so the medication is accumulating in the body, resulting in side effects, and so it predicts the risk of the higher risk of side effects in patients that are poor metabolizers, which does not mean that they'll necessarily have side effects, but it's more likely for those patients to have side effects. There are some risks associated with pharmacogenomic testing related to health insurance and employer discrimination, which has been overcome to some degree, by GINA, which is Genetic Information Non-Discrimination Act. Health insurers and employers cannot use or access pharmacogenomic testing results for hiring, firing, promotions, demotions, coverage or non-coverage of medications, or health conditions. There is some limitation of GINA in terms of life insurance, long-term care, and disability, which are not covered. Because pharmacogenomic testing is not whole genome testing, it does not predict disease risk, but sometimes, depending on our findings, we're able to assume or predict secondary findings. Cost of testing. Tests can be expensive, and it depends on your insurance. Copays can be variable, and insurance is usually billed. If the claim is denied, maximum out of pocket is usually around $375, depending on the testing company used. Clinical services are significant and include numerous things. Those will be addressed later on in this presentation, but they're billed using medical codes and CPT codes and are time-based. Cash services are also available, which includes the test and the cognitive services at a cost of $500. Some HSA, and that's health savings accounts and medical savings accounts, may be billed, but coverage is dependent on the plan. As far as the testing procedure, a buccal swab is usually taken and is sent to the lab for analysis. It usually takes about 2 days to get to the lab by mail, and the results are returned in 5 to 10 days by the lab. Interpretation of the results and implication for the patient are done by a pharmacist or other qualified medical professional in about 3 business days, and then the patient is invited back in, and the pharmacist provides those cognitive services to the patients. The cognitive services take about 30 to 45 minutes, and results are reviewed with the patient and their family if the patient so desires, and the results are explained and how they can influence current and future medication choices. Also addressed are current medication concerns and determination if recommendations for drug therapy changes are needed. The pharmacist then works with the patient and or their family to determine which providers need to receive interpretive pharmacogenomic results, and if recommendations are also needed to be shared with that provider or those providers. The future of pharmacogenomics is a relatively new area of medicine. Many studies are on the way. There are development of tailored drugs to treat a wide variety of health problems, and some of these include cardiovascular disease, Alzheimer's disease, cancer, HIV/AIDS, asthma, and potential for other areas as well. So, to conclude, pharmacogenomic testing is a very important tool for doctors who are prescribing medications for you. Testing before you have a medical emergency is very important because when you're on the operating table or have an emergency situation, it would be nice to have your results available. Currently, Medicare only pays for clopidogrel testing and antidepressants and antipsychotic medications or mood stabilizers. And as a result, there are many instances where patients would benefit while in the hospital from pharmacogenomic testing. If their results were already there and the doctors could treat them instead of starting something that they could possibly have severe reactions to, that would be quite a blessing. And so hopefully you will see the benefit of doing pharmacogenomic testing. I will be sharing some of my results in my other presentation coming soon. Thank you for your attention and have a great day.